बेटा सेशन स्टार्ट हो रहा है, बच्चों को मत आने देना, थोड़ी सी आवाज़ कम करना। मेरा रूम में सेशन स्टार्ट हो रहा है, बच्चों को मत आने देना, आवाज़ कम करना। बेटा सेशन स्टार्ट हो रहा है, बच्चों को मत आने देना, थोड़ी सी आवाज़ कम करना। मेरा रूम में सेशन स्टार्ट हो रहा है, बच्चों को मत आने देना, आवाज़। All right, good evening friends. Welcome to the most important PYQ sessions of oral and maxillofacial surgery. I am Dr. Himani Joshi, the original guru for oral and maxillofacial surgery. And today I am going to talk about not just the most important PYQs, but also the most controversial PYQs of oral surgery. Okay, a lot of times students ask me doubts related to a particular question where the concepts are not clear. Okay, so the today's aim of today's discussion will be to clear all the controversies, all the difficulties around certain questions which are the most important ones. All right, so let us begin. The first question here is, a patient has uncontrolled bleeding after tooth extraction. All right, which of these can be used for management? Now the options you have here are adrenaline soaked gauze placed locally, application of triclosan, ice packs, or use of chlorhexidine. Okay, now whenever this kind of question comes to the exam, you have to rule out the options. Okay, sometimes it is easy to pick the answer. Sometimes you feel that the answer is not correct, but after ruling out, you have to reach to that answer. For example, we all know that adrenaline causes rebound bleeding. Alright, that is why we don't commonly use adrenaline or NORAD or any vasoconstrictor to arrest the bleeding from the extraction socket, because there are chances of rebound bleeding. But out of the options that are available, sometimes what the examiners do is they just pick up a question from the very old question bank and they just put it like that. So these kind of questions will come only when this is going to happen. Okay. Nowadays, there are many better styptics available, many other drugs available for local application, for systemic application, for which can be used to arrest bleeding. Alright, so this is one example of question which was just picked up like that and put into your exam recently. Okay, now let us look at the options. Use of chlorhexidine. Chlorhexidine is not at all related to hemostasis. It is not a hemostatic agent. It is used for antisepsis. All right, it is available in the form of mouthwash, scrubs, hand washes, surgical scrubs, not at all related to your hemostasis. Ice packs. Okay, now the latest literature says that ice pack is only a placebo. Okay, it will only make the patient feel a little better because numbing will cause the pain sensations to go less. It has no direct role in hemostasis. It has no direct role in healing. It has no direct role in even pain management. Alright, so ice packs are actually useless. Application of triclosan. Again, triclosan is also an antibacterial agent, not at all related to hemostasis. So these three options are ruled out. So the only option which is left here is an adrenaline soaked gauze placed locally. Alright. So this is how you will choose an option after ruling out. Obviously, if you ask any oral surgeon or anybody who is doing regular extractions, he will not use an adrenaline soaked gauze. He will rather use a tranexamic acid soaked gauze. Tranexamic acid is much easy to, it is easily available. You can easily soak the gauze. You can pack the site and it arrests the bleeding. It is an antifibrinolytic agent. Which is very, very easily used to arrest the bleeding locally. And the good thing about Taxid is the brand name, tranexamic acid. The good thing about tranexamic acid is it can be used both locally by applying it on a gauze and packing it and asking the patient to bite on it, and it can also be used systemically, that is IV. So whenever we are doing major surgeries like a Leafort 1 surgery where we are expecting a lot of bleed, Preoperatively or intraoperatively also, we give tranexamic acid when it is not contraindicated. We give tranexamic acid for a generalized reduction in loss of bleeding. Alright, so ideally the best option would be local application of tranexamic acid soaked gauze. Alright, but out of the options available, this is what you choose. Now I will also discuss a similar question. Which of these drugs can be injected systemically to control bleeding at the site of extraction? Okay, now 1% adrenaline can never be administered systemically. It's a very high dose for systemic administration, and we never use adrenaline. IV for bleeding control from a local source. Oxidized cellulose and collagen form. Okay, so Oxycell and gel foam, these are the brand names, very commonly used for hemostasis but locally. Okay, these are the local styptics or the local hemostatic agents which you can pack into the bleeding site, into the extraction socket, and arrest bleeding. Whereas the question is asking you systemically. Alright, so very easily you can rule out option A, B and C, and you will come to ethamsilate. Alright, ethamsilate is also a systemically available agent which you can use for hemostasis, intravenously used. Okay, not very common. Again, it is used for major bleeds and all, but commonly we use tranexamic acid. Alright, very quickly now I am going to give you a list of styptics and a list of IV or the intravenous agents that are used for hemostasis. Okay, so vasoconstrictors. Let us talk about vasoconstrictors. Vasoconstrictors like adrenaline or noradrenaline. Okay, now we are talking about the local. These are all the locally applied agents which are called styptics. Okay, styptics are the locally applied agents. Okay, we don't usually use this commonly because of the risk of rebound bleeding. Okay, the next group of agents are the absorbable agents. The absorbable agents like gelatin based agents, gel foam, Surgi foam, okay, and Sterispon, Flow Seal, and all these agents. The next one is oxidized cellulose, okay, commonly available as Oxycell and Surgicell. Okay, oxidized cellulose also helps in vasoconstriction locally. These are all the local agents. That is why they are called styptics, locally acting agents. And the third absorbable agent is your microfibrillar collagen. Microfibrillar collagen, commonly available as Avitine. Alright. Apart from the absorbable agents, so this is one category, this is another category. The third category is your thromboplastic agents. Thromboplastic agents like thrombin, very commonly available in the glues which are available in surgeries, and your Russell Viper venom. Not very popularly used but can also be used. Just to complete the list, I am giving you this. Alright. Now other than that, there are other generalized agents like astringents, the tannic acids and zinc chloride, ferric chloride, tannic acid, zinc chloride, ferric chloride, and alum, Fitkari. Patient ne Fitkari rakh li. The patient has put a piece of potash alum, and because of that there is vasoconstriction, because it's a styptic, it's a astringent, so it will just help in vasoconstriction and locally allow the hemostasis in that area. Other than that, there are adhesives, not commonly used as hemostatic agents, but it can be used, like the fibrin sealants, which are very popular, and the cyanoacrylate adhesives. Okay, and other than that, there are other agents like the bone wax, which are used in bony bleeding. Okay, whitehead varnish, and your calgetics, that is your calcium alginate dressing. Calcium alginate dressing. Alright, so these are the popular styptics which we use theoretically and practically, and I have told you the advantages and disadvantages of all. Out of these, the most popular and the most commonly used is tranexamic acid. Okay, this is the last category, which is the antifibrinolytic agent. So in local application also, as a styptic also it can be used, and as a systemic application also it can be used. Okay, so these are the locally applied drugs. Now what are the systemically applied drugs? Just let me tell you some of them also. So commonly we use tranexamic acid, ethamsilate, epsilon aminocaproic acid, EACA. Mostly we use it in major surgeries, but sometimes, in rare cases it could be used in tooth extraction complications also. And other than that, then you use the blood products like the platelet infusions or cryoprecipitate, fresh frozen plasma, vitamin K, all these things depending on the patient's medical history. Alright, so these kind of questions are very, very popular in NEET. Now I have told you the local agents, the systemic agents, one agent which can be used both locally and systemically. So please answer these questions correctly now in exam. Okay, going to the next question. Now epinephrine is a very, very fearful drug. Okay, everybody fears giving local anesthesia with epinephrine. That is, okay, kuch bhi BP slightly raised, don't give adrenaline. History of MI, don't give adrenaline. So yes, you should fear adrenaline, but in the right amount. Not every time you should fear adrenaline. The question that usually comes is how much epinephrine can be administered to a patient with angina, to a patient whose cardiac reserve is not as great. Okay, so the answer is 0.04 milligram. Okay, now let us look at the list of conditions where you have to avoid or give very, very minimal epinephrine. All right. Patients where blood pressure is more than 200 by 115. Okay, normal blood pressure is 120 by 90. So if a patient comes to you whose blood pressure is 180/100, don't worry. You can give adrenaline, local anesthetic with adrenaline. Okay, adrenaline has a lot of advantages. So don't just avoid adrenaline just because slight raise in blood pressure. Alright, only when it is highly raised, only when it is raised in the range of more than 200 systolic or 115 diastolic, then of course you should avoid adrenaline or give it very, very minimally. Alright, patients with uncontrolled hyperthyroidism. Okay, now the examiner will ask you that the patient is taking propyl thiouracil for his hyperthyroidism. Okay, that means he is a controlled hyperthyroid. Okay, that means his thyroid status is euthyroid now. He's normal. Anybody who is hypothyroid or hyperthyroid but is taking a treatment, that means it is a normal patient. Please give local anesthetic with ADR in such patient. Only when the thyroid status is uncontrolled, that is, the patient doesn't know that, okay, he has a goiter and he doesn't know why that is happening. That means, yes, he can have an uncontrolled hyperthyroid goiter. Or if the patient knows about it but is not taking any treatment or medication. Okay, because more than the tooth, there will be other problems with the thyroid status. So, uncontrolled hyperthyroidism is a contraindication definitely to use of adrenaline. Okay, the risk of thyroid storm. Okay, so any patient who is taking drugs for hyperthyroidism or any patient who has already undergone surgery for hyperthyroidism is a euthyroid patient. So treat him normally. Uncontrolled, yes, don't use adrenaline. Okay, then next is patient with severe, again important is severe cardiovascular disease. Normally, as dental surgeons, we don't usually see a lot of cardiovascular patients. So we are fearful of any patient who has a history of cardiovascular disease. But not every patient is in the severe category. Okay, any MI which is less than 6 months, you avoid adrenaline. Not because anything bad will happen, just for the risk of reinfarction. just for the risk of reinfarction, you will avoid using adrenaline. Okay. Less than 6 months after a stroke. What is cerebrovascular accident? It is a stroke. So whenever there is a stroke or an MI which is less than 6 months old, you avoid giving ADR in that patient. With episodes of angina or unstable angina, whenever there is a stable angina with recent episodes or whenever there is an unstable angina, you avoid adrenaline. Cardiac dysarrhythmias without, whether the patient is not taking therapy or in spite of therapy, there is still arrhythmia, tachyarrhythmia or bradyarrhythmia. So arrhythmic conditions, definitely avoid adrenaline. Okay, we know that the treatment for tachyarrhythmia is lignocaine. Okay, but not adrenaline. So you will avoid adrenaline in dysrhythmic patients. And whenever the patient is undergoes a CABG, a coronary angiography or coronary artery bypass surgery, less than 6 months. So whenever there is a stroke or MI less than 6 months, there is a risk of re-happening of the same event. There is a risk of re-MI. There is a risk of re-stroke. So you avoid ADR in such patients. Although this is also contested nowadays that it's not really the ADR which is causing stress, it is the procedure which is causing stress. So, but theoretically in these conditions we have to avoid. In patients who are undergoing GA with halogenated agents, we hardly use halogenated agents now. We normally use fluoranes, isofluranes, desfluranes, sevoflurane. But if halogenated agents are used, you avoid infiltration with ADR. And patients who are on non-specific beta blockers, MAO inhibitors or TCAs, you avoid. It's not that it is contraindicated, but you usually avoid. So this is the only list where you will avoid adrenaline or use it very, very minimally. Other than that, you can use it normally. 1:80, 1:1 lakh or 1:2 lakh concentration. If you guys have any doubts, you have the liberty of typing in your doubts in the chat box and I'll be happy to answer. Okay, next question. A patient reported with a long-standing carious lower molar with a sinus tract in the submandibular area. During treatment, the doctor reportedly gave local anesthetic injections because the patient was constantly complaining of pain during the procedure. So, he repeatedly gave LA, probably without keeping a count of how much LA is already given. Suddenly, the patient developed slurring of speech, confusion and through a seizure. Okay, what complication has happened here? So we all know any CNS or CVS manifestation, it is because of LA toxicity. Okay, and at what level of toxicity does a patient throw seizure? When usually the blood level is above 7.5. Alright, so your correct answer will be local anesthetic toxicity with a blood level above 7 milligram per deciliter. Now, let us look at this very, very important table which is there in Malamute. Okay, we have all seen this table. We have read this table, but we don't look at it very, very carefully. I am just going to show it to you that at the CNS level, when we are talking about the central nervous system, the only effect of toxicity, see up to 4, it is not toxic. Up to 4, it is rather an anticonvulsant action, right, for lignocaine. Alright, up to 4, it is normal. It is rather it is treating cardiac arrhythmia, see, cardiac anti-arrhythmic action. So initially it is very, very helpful even if it goes into the circulation. But if more than 4 goes into the circulation, the only effect on CNS will be depression. The only effect of lignocaine toxicity or local anesthetic toxicity on CNS will be depression. Now, depression doesn't always mean that the patient will be sitting in a corner of the room and lying down. No, that is not what depression is. CNS depression can manifest in various ways. If the patient who is looking normal till now, suddenly he starts talking excessively. What is happening to me? I'm not feeling alright. He starts hyperventilating. He is showing excitation. But that excitation is also a manifestation of CNS depression. His CNS is depressed, but the manifestation is a behavioral excitation. Alright, which is exactly what this table tells us. at the blood toxicity level of 4.5 to 7 microgram per ml, there is CNS depression. Definitely there is depression, but it can manifest as excitation. What excitation? Not CNS excitation, behavioral excitation. Okay, so हमें लगता है excitation means CNS is excited. No, CNS is depressed. It is CNS depression, but the behavior is manifesting as excessive speech, slurred speech, drooling, excessive saliva, excessive sweating, hyperventilation. So patient is looking like he's hyper. Doesn't mean his CNS is hyper. These are all signs of CNS depression. Alright. When the toxicity goes beyond 7, that is at the 7 to 10 level, then he will throw a seizure. Beyond that, it is still depression. But the depression's manifestation is now a seizure. Alright. And even beyond that, when the toxicity is beyond 10 microgram per ml, even seizure will not come. There will be a generalized CNS collapse. That is a cerebral collapse. Okay, or a CNS generalized depression. कोई discharge नहीं होगा. Alright. So all the toxicity at the CNS level is depression only. The manifestation of depression can be initially like an excitatory behavior at the level of 4 to 7. Later on, beyond 7 to 10, it will be manifesting as a seizure. Now, some people can call seizure also as an excitatory behavior, because seizure means excessive involuntary movement of the muscles. So that can also look like, oh, excessive movement means ये तो hyper हो रहा है brain. No, these are all signs of CNS depression. The manifestation is either behavioral excitation or seizure or a generalized depressive state. Alright. So this is very, very important. A lot of MCQs come from this very table. So you should know this flow chart, this table, and normally questions are asked on CNS. This time they can ask on the cardiovascular system also. So please understand these tables. Remember the values, at what level there will be ECG alterations, at what level there will be massive vasodilatation, because we all know lignocaine is a vasodilator. Except ropivacaine and levobupivacaine and cocaine, all local anesthetics are vasodilators. So when there is a vasodilatation peripherally, heart में blood नहीं आएगा. Blood will not reach heart and there will be a cardiac arrest at the end. Alright. So please understand this table very nicely. Okay. Next very common question which is asked in NEET is calculate the Pedersen difficulty score in whatever X-ray that is given to you. Alright. Now usually the question will be on mandibular third molar. Okay. In this we know the Winter's classification: mesioangular, horizontal, vertical, and distoangular. Okay. Mesioangular is 1, horizontal, vertical is 1 or 2 depending on different books. Sorry, 2 or 3, and distoangular is definitely 4. Examiner will not give you controversial things. Most of the times he will not give you controversial things. Either he will give you mesioangular or he will give you distoangular. So you know that your score is either 1 or 4. Okay. Here it is not difficult. Then we come to levels. Okay. Level 1, 2, 3. Now how will you decide? It is not difficult. See, if I zoom in, all you have to do is you have to look at the adjacent second molar. Okay. Now this is my adjacent second molar. This is the crown. This is the cemento-enamel junction. This is the CEJ. That is the junction between the crown and the root. You have to check at the level of the CEJ. If the highest portion of the crown of the third molar, okay, this is my 8. If the highest portion of the crown is at or above the occlusal level, suppose this is above the occlusal level, then it is very easy to remove. My score will be 1. Okay. If the highest portion, you have to look at the highest portion of the third molar. The highest portion of the third molar is at or above the occlusal level, then my score becomes 1. If the highest portion is below the occlusal level but above the CEJ, now if I draw a line like this, definitely the highest portion of the third molar is below the occlusal level but above the CEJ. So that makes it a score of 2. And if the highest portion, suppose this tooth would have been even deeper, suppose this tooth was somewhere here, okay, like this. So the highest portion of the crown of the third molar is below the CEJ. That makes it really, really difficult, and that is the position, third position. So level is 3. So that is how you decide a score of 1, 2, 3 based on the depth of the third molar. If the highest portion of the crown is above the occlusal level or at the occlusal level, 1. If it is between the occlusal level and CEJ, that is above the CEJ, it is 2. And if it is below the CEJ, it becomes 3. Okay, so that is how you decide the depth of the third molar, the scoring based on the depth. Now, how will you decide the ramus relationship? How much into the ramus it is gone? I will tell you a very easy method of finding it out. Assume that the tooth is straight. Okay, now here we can see that this third molar is mesioangular. Assume that the tooth is straight. Okay, if I just straighten this tooth up, so it will be something like this. Okay, and the roots will be like this. Okay, so if the tooth would have been straight, how much into the ramus would it go? Okay, it would be something like this. The ramus relationship would be something like this. That means almost whole of the tooth is into the ramus. Or what you can do is very, very simply, just draw a line. Just draw a line like this. Okay, and normally this is the lingual plate. Okay, and just उस tooth को सीधा करके देख लो. If you think that the whole tooth, there is enough space for the whole tooth to erupt. Okay, this is the maximum width of the tooth. Suppose the ramus is like this. Then I have enough space to cut the tooth and remove it into 2 parts easily. Okay, if the ramus is here, right? But the ramus is not here. So that in that case, the position, the ramus relationship score will be 1. If the ramus is like this, the tooth is out, the ramus has enough space to allow the eruption of the tooth. So if the ramus would have been here, the score of this tooth as per ramus relationship would be 1. Okay. Second is when there is less space but still itna bhi kam nahi hai. It is still not too less. Like suppose like this. So yes, the space is less but still not as less as this. So 2. And if you feel that the whole tooth is just inside the ramus, like this situation, your score will be 3. Alright. So this is how you have to actually calculate the score. Now in this patient, in this case, it is mesioangular. Obviously you can see it is mesioangular. So score is 1 plus. It is above the CEJ, below the occlusal level. So score is 2 plus. Definitely the whole of the tooth is inside the ramus of mandible. So score is 3. Total score is 6 and that is your answer. Okay. So in exam, take your time. If you want, you have the back side of your admit card which can be used as a rough sheet. Okay. The back side of your admit card is your rough space. Use that rough space, draw this diagram. Okay. Make a mandible, make a second molar and make a third molar in a relationship as you can see. So as you can see in the x-ray, make that relationship on that rough sheet. And based on that, you calculate your score of 1, 2, 3. Based on the depth, based on the position, based on everything. Alright. So this is another question commonly asked. Students make mistake ki ma'am mesioangular to pata chal raha hai, but depth we don't know or position we don't know. Okay. So this is how you will calculate. Okay. Coming to the next important and controversial question. A 7-year-old child currently presents with reduced mouth opening and lopsided chin to the left side. He gives a history of trauma for which he underwent a surgery for the same in the past. What is the right treatment for this child at present? Alright. So, you know that reduced mouth opening, chin deviation to the left side, history of trauma, everything makes it a diagnosis of TMJ ankylosis. Alright. So, it's not OSMF. What are the things which can cause reduced mouth opening? OSMF? I don't think anything is related to areca nut or anything here. There is a clear-cut history of trauma. There is reduced mouth opening. Chin is deviated because it's a child. It's a growing child. And it is straightforward diagnosis of TMJ ankylosis. He also underwent a surgery for the same in the past. That means already he's operated once for TMJ ankylosis surgery. That means this is a case of re-ankylosis. This is a case of re-ankylosis. That means whoever did the surgery, either the surgery was not done properly or the post-operative physiotherapy was not done properly. And re-ankylosis has happened. Okay. So now all you have to do is just go with the Caban's protocol. Okay. The Caban's protocol, the modified Caban's protocol in children, where you know that you have to make an adequate gap with gap arthroplasty. After the gap, you have to give a growing graft because the child is a growing child. It's a 7-year-old child. So in a 7-year-old child, the rule is you have to give a growing graft. What are the two growing graft? Either you will give a costochondral graft, which is a graft, or you will do a neocondylogenesis with distraction osteogenesis. Transport distraction of the ramus and create a new condyle. Both these will allow growth and both these are the right treatment for a growing child. Now look at the options. Condylectomy. If this is the mandible, this is the glenoid fossa and this is the ankylotic mass. Is there a condyle? To do a condylectomy, can I tell that this is the condyle? Obviously not. There is no condyle. How can I do a condylectomy? Right? Because the definition of ankylosis is that it is a fusion of the condyle with the fossa. So when there is no condyle, how can you do a condylectomy? So it's not the right term. Alright? So condylectomy is wrong. Next is gap arthroplasty. What is gap arthroplasty? You make a cut from here. You make a cut from here. And you remove this ankylotic mass. So what will happen? You will open the mouth. Definitely it will correct the mouth opening of the patient. Will it correct growth? No. Will it correct asymmetry? No. So in a growing child, it is not the fully correct treatment to just do a gap arthroplasty. So it is also wrong. What you have to do is give a growing graft. That is why the correct answer is option C, interpositional arthroplasty. That means after doing this gap, you take a rib graft, a 6th rib or a 7th rib, put that rib like this, fix it with screws, and this part has a chondral part, which is the cartilaginous part, which is a growing cartilage. It's a hyaline cartilage which is present in the ribs. It's a growing cartilage and you put that cartilage. So that is first option. Second option is you can just take a part of the ramus, posterior part of the ramus like this. Okay, cut it, do an osteotomy of the ramus, fix a distractor, turn the key of the distractor and push this ramus upwards to create a new condyle. So these are the two options in a growing patient. Alright, so this is the correct answer. All those who are watching, I'll be very happy if you give me a thumbs up on the chat so that I know that you guys are understanding everything. Are you understanding everything? Just give me a thumbs up in the live chat on the YouTube channel so that I know you guys are understanding. Alright, very good. Coming to the next question. A 5-year-old boy was operated for TMJ ankylosis using costochondral graft. Okay, that is the correct protocol. Okay, after TMJ ankylosis surgery, we do a costochondral grafting. 8 years later, okay, it's a long time. 5-year-old may, you have done the surgery. 8 years later, he comes with a deviation of 9 mm to the non-operated side. Okay, we all know that the only disadvantage with CCG, apart from an additional donor site, the only disadvantage with CCG is overgrowth. Overgrowth is the only disadvantage. Okay. Now, sometimes the examiner tries to fool you. He will say that a patient, child patient, CCG was done and he comes to you after 4 weeks. Can CCG overgrowth happen in 4 weeks? No. If it's coming in 4th week and you are seeing some asymmetry, It is usually due to the temporary facial nerve palsy. Okay, immediately after surgery, immediate post-op, if the patient is coming with facial asymmetry, then it is because of the facial nerve palsy, because facial nerve is also in this region and ankylosis is also in this region. So the surgery causes a temporary facial palsy which happens immediately post-op. Okay, facial palsy will happen immediate post-operative period. It will not happen 8 years later. It will happen immediately after surgery, and it will either stay if it is a permanent facial palsy, or it will slowly resolve if it is a transient facial palsy. Usually after TMJ surgery, there is a transient facial palsy which resolves slowly as the swelling goes away. Okay, so that is what you are going to see in the immediate post-operative period, that is after surgery and for a few weeks after surgery. This complication will not happen 8 years later. 8 years later, growth related complications can happen, which is graft overgrowth. That will happen slowly as the child grows. Slowly, one side is growing normally, the graft side is overgrowing, and that will cause the deviation to the opposite side, to the non-operated side. Okay, chin deviation, this is a very crude option, and reduced mouth opening will not cause deviation. Alright, so the correct answer here is graft overgrowth. Very quickly, let me show you this case. So this boy, as you can see, he's an unoperated cases of ankylosis. You can see that this is the midline. Okay, this is the maxillary midline, and the mandibular midline or the chin is deviated to the, if this is right and this is left. Okay, the chin is deviated to the right. Why? Because this side is growing and this side is non-growing because of ankylosis. This is the non-growing side. That is why we say there is always fullness on the non-growing side. You will see that the face is full, bhara face hai. And there is flatness on the growing side. Okay, and chin deviation because this side is not growing. So this side is not going to push the mandible. This growing side is going to push the mandible to the opposite side. Okay, so this is an unoperated case of TMJ ankylosis. Now imagine we have done a surgery and we have fixed a costochondral graft here. Okay, suppose we have fixed a costochondral graft here. Now as the child grows, this side is also growing, this side is also growing, but this side is growing excessively. It is overgrowing. So opposite side shift. What will happen is now the chin will go to the opposite side because this is growing, but this is growing faster or this is growing more. So this will cause deviation of chin to the non-operated side. Okay, to the non-operated side. The only reason for chin deviation to the non-operated side is either condylar hypertrophy or graft overgrowth. Only in two conditions there will be chin deviation to the opposite side: graft overgrowth or condylar hypertrophy. Alright, so this is the correct answer to this question. Okay, next question. 2-year-old child has history of difficulty in breathing, snoring and repeated awakening in the night. Patient reports a trauma due to fall at 2 months of age. Okay, from 2 months till 2 years, he has difficulty in breathing, snoring and repeated awakening in the night. What is the cause of the problem? Now the actual cause of the problem is obstructive sleep apnea. Okay, difficulty in breathing causing apneas and hypopneas, snoring which is a sign of reduced airway, repeated awakening due to the hypoxic and anoxic episodes, daytime somnolence. These are all features of obstructive sleep apnea. Why is a history of trauma given here? Because it is very common to have OSA in children with bilateral TMJ ankylosis. Very common, children with bilateral ankylosis, their mandible stops growing because bilaterally there is ankylosis. So mandible doesn't grow, face is growing. Everything is growing, but mandible is not growing. So that becomes an obstruction to the airway. Okay, and this is the primary cause of obstructive sleep apnea, same as we see in Peri-Robin sequence. Peri-Robin sequence. Same thing. In that also, the mandible doesn't grow, not because of ankylosis, but because of congenital retrognathia, congenital micrognathia. The mandible is very small. So that becomes an obstruction to the airway. Okay, so the cause is bilateral TMJ ankylosis. Also here, the treatment that you will do will primarily be the treatment for OSA. First treatment will be the treatment for OSA. Second treatment will be the treatment for TMJ ankylosis. If it is severe OSA, you will first treat OSA. If it is mild OSA, you can do the OSA surgery and the ankylosis surgery together. What is the surgery for OSA? Body distraction. Okay, this is not the same as mandibular ramal distraction that we did in ankylosis. This is mandibular body distraction. You take the mandible forward bodily. That is the treatment for advancing the mandible in OSA. You can do it with ankylosis treatment. You can do it before ankylosis treatment depending on the severity of OSA. Okay, very quickly I will show you this case. So this, like we know, is the normal airway. I have shown it many a times in our previous lectures also. This is the normal airway. This is the nasal airway. This is the oral airway. The nasal airway goes into the nasopharynx, the oropharynx, the laryngopharynx where you have this epiglottis there, and it enters into the trachea. So you can see the width of a normal airway. Okay. But in patients whose mandible is present backwards, retrognathic mandible, Peri-Robin sequence, bilateral TMJ ankylosis, you can see here there is an ankylotic mass lying here. So it's a bilateral ankylosis. You can see how backwardly placed the mandible is. And look at the airway here. Nasal airway hardly appreciated. Yes, some pharyngeal airway is there. And this is the airway. You can see the difference in the volume of airway. So the treatment here is before releasing the, because if you release the ankylotic mass, if you do a TMJ ankylosis surgery in a severe OSA, what will happen is when the patient opens the mouth, what happens when I open the mouth? The mandible goes even backward. So in a patient, if you have a severe OSA and you do ankylosis surgery first, mandible opens and airway worsens. So in severe OSA, you never treat ankylosis first. You always do the OSA surgery first, which is body distraction. So what I will do is, I will put an osteotomy in the body of mandible bilaterally. I will fix a distractor like this. I will turn the key. I will advance my mandible. I will bring this mandible here. Instead of here, I will bring the mandible here. I will distract good 10, 12, 14 mm as much as it is required, and I will bring the mandible forward. So it will automatically open the airway. Then I will do the surgery for ankylosis. Okay, so this is the protocol for ankylosis. This is how you put a distractor. Okay, in the angle body region, you put an osteotomy. You fix a single vector distractor. You distract anteriorly. This is what happens in a child. You can see how much retrogenia is present here. And after distraction, it is almost a straight profile. So this is what you need to do in obstructive sleep apnea cases. Okay, next question. Which of these surgical orthodontic procedures is least stable? We know that maxillary widening is the least stable. This table is what creates a little bit of confusion. Is you have to remember this table. Okay, nobody is going to ask you these middle things. Nobody is going to ask you this. Either they will ask you the most stable or they will ask you the least stable. Okay, nobody asks you middle things. Okay, now always remember, whenever there is a gap between bones or whenever there is a occlusal discrepancy, that is open bite, cross bite, edge to edge, cusp to fossa relationship is not there. Okay, these two are the biggest causes of failure of orthognathic surgery. or least stability or reduction in stability. You can say that, okay, I have done a maxillary widening and I have put a bone graft there. So there is a continuation. No. The original bones, there is a gap. So whenever there is a gap, there will be a reduction in stability. The third thing which I missed here is the pterygomasseteric sling. Whenever you kind of push the pterygomasseteric sling, it will also cause your reduced stability. It will cause a relapse. Okay. Now, the least stable out of all of these, the least stable is maxillary widening. Why? You are doing a Lefort one. Okay. You are cutting the maxilla. Then you are cutting it from middle. Okay. So, 3 parts. One cut here, one cut here. So, one maxilla here, one maxilla here, and you are separating it. So, it's the most unstable surgery. That is why instead of a maxillary widening with orthognathic surgery, we do a SARPE. We do a surgically assisted rapid palatal expansion. We distract the maxilla whenever we want to widen it, instead of doing a maxillary widening by orthognathic surgery. Similarly, when you down fracture the maxilla, this is the rest of the midface and this is the maxilla which you are taking down. What it is creating? A gap between the original bone and the down fractured bone. So a gap, whenever there is a gap, the stability will be less. So least stable is maxillary widening. Slightly more stable is maxillary down fracture. And slightly more stable but still very unstable is mandibular setback. Why mandibular setback? Because of the pterygomasseteric sling. We all know that here there is a masseter. Inside there is a medial pterygoid. At the angle region, the masseter and medial pterygoid fuse to form a pterygomasseteric sling, which is a very, very rigid and tough structure. So if you take your mandible and you push it back, it usually bounces back because of the sling. That is why we avoid doing BSSO for greater setbacks. We do a vertical ramus osteotomy for bigger setbacks. Okay, so these are the least stable. Least is maxillary widening, slightly better maxillary down fracture, slightly better is mandibular setback. But altogether, these 3 are the least stable surgeries. Opposite to that, maxillary setup. That means you are impacting the maxilla with the rest of the midface. So there is an overlap between the bones. Instead of a gap, there is an extra overlap. There is an impaction of maxilla. So it's definitely very stable. Okay, mandible forward to some extent. Not कि भाई आपने 18 mm आगे कर दिया. No. A little bit of mandible forward because you're not injuring or you're not hindering the pterygomasseteric sling. So that is also kind of relatively stable. And genioplasty. Chin in any direction. Genioplasty is also very, very stable procedure. Okay, you can take the chin forward, backward because no direct influence of muscles. Alright. So this table, please understand, please remember, at least the most stable and the least stable you should know and the reasons behind it. Okay. Alright. Coming to the next question. Another controversial question. 23-year-old boy had road traffic accident and sustains a fracture of the angle of mandible. Which of these is the best treatment option for him? Now here, you have a single fracture of mandible. You have a single fracture of mandible. Whenever you have a single fracture, very easily you can use the Champy's principles. You can use the Champy's principles and you can use mini plates. Alright, we all know the rules for mini plates. When it is an anterior mandibular fracture, that is between the mental foramen, symphysis or parasymphysis, you use 2 mini plates. Whenever there is a body or angle fracture, you use a single mini plate. In the angle fracture, you start putting the mini plate from the lateral border. You curve the mini plate and take it medially like that. It's like a propeller, in a propeller or a fan shape. Alright, so this is the correct. So this is just diagrammatic. This is not in the air. This is actually going lingually. Alright, so this option of 1 mini plate on the external oblique ridge mediolaterally is the best option for a single fracture of mandible. Similarly, if that single fracture is there in the parasymphysis, I will put 2 plates, one in the superior border just below the apices of the teeth and one at the inferior border, and fix them with minimum 2 screws on both sides. If there is a body fracture here, I will use a single plate in the neutral zone. Okay, so these are the Champy's principles. Please remember, Champy's principles only apply when there is a single fracture of mandible. Similar question, I am coming down. In case of linear fractures in symphysis and angle region, now here there is a dual fracture. Very common. In mandible, combination fractures are very common. Now which treatment is correct? Too many plates at symphysis and one in angle. Yes, this is correct as per the Champy's principles. As per the Champy's principles, it is correct. One mini plate at symphysis and two at the angle. No, this is wrong. DCP at both sides is a must. No, this is also wrong. But A is also wrong. Why? Because whenever there is more than one fracture in mandible, Champy's principles do not apply. Champy's principles cannot be applied in more than one fracture of mandible. It can only be applied in single linear fractures. Comminuted fractures, atrophic fractures, combination fractures, you cannot apply the Champy's principles. So your correct answer will be intermaxillary fixation. In this case, you can't do either A, B or C. It will fail. C will not fail, but it's not a must. Alright. So which treatment is correct? Either you do IMF, that is treat both the fractures with intermaxillary fixation, or if you have to do ORIF, the correct answer will be, so there is one symphysis fracture and one angle fracture. In this, the rule is the more anterior fracture or the more accessible fracture, you have to put a rigid load bearing plate, which is a reconstruction plate. Okay. So whenever there is more than one fracture, the more anterior or the more accessible fracture, you have to put a rigid fixation. You have to put a rigid fixation. What is rigid fixation? Rigid fixation is recon plate, reconstruction plate. Till the time you do it, your treatment is wrong. Your treatment will fail. Okay. Once you have put the recon plate, now you have converted the dual fracture into a single fracture. Now instead of 1, 2, 3 parts of mandible, now part 1 and part 2 have united rigidly. Now that has become a single part. So now it's a single fracture. Now you do whatever you want. Now you can put a mini plate just like this in the angle region because it is less accessible. So I will not put a recon plate in the angle because it is difficult to put a recon plate in the angle. So I will put it in the easier fracture, which is the symphysis fracture. Okay. So remember, whenever there is more than one fracture, very commonly dual fractures, combination fractures in mandible, you treat at least the anterior fracture with a rigid plate. Like for example, bucket handle fractures, 2 body fractures. Put a long reconstruction plate, treatment is over. Alright. So at least one has to be rigidly fixed. Okay. Alright. Coming to the next. Please keep asking your doubts if you have any. If it is cleared, I am very happy. Next question is from pathology segment. Marginal resection means. What is the meaning of marginal resection? So I am just going to tell you the meaning of all the terminologies. Okay. Whether it's a cyst, whether it's a tumor, whether it's a vascular pathology, whether any pathology, any pathology in the bone. Any bony pathology. Okay. What are the things which you can do? Okay. First thing which you can do is curettage. Okay. Where do we use curettage? Mostly we use it in cysts. Okay. What is curettage? Just like, you know, you have seen a coconut. Okay. Coconut mein you drink the coconut water. Then the coconut wala bhaiya removes the malai, removes that thick white part. How he removes it? With a scoop. Just like that, you remove the lining of the cyst from that coconut. The coconut is the bone and that cyst is that inside part of the coconut. Just like you remove the coconut ka malai, similarly you remove the lining of the cyst, which is known as curettage. Just scooping out or scraping out the lining. Second is marsupialization. What is marsupialization? Marsupialization is creation of a window. Okay, that is, you open the wall of the cyst so that all the fluids can drain and automatically it will shrink. Alright, so that is marsupialization. Third thing is enucleation. If you think that the lining is very, very thick, okay, just like a water balloon, you can just hold the water balloon with the water inside. You don't have to curate it out like a nariyal pani. You can remove the whole block in one piece. If you remove it in toto or complete removal of the lining, it is called enucleation. Just with the nucleus, you remove the whole thing. So that is enucleation. All these three things are used for cysts, mainly used for cysts. Now, what do we do for tumors? For tumors, we use the word resection. We use the word resection. Why do we use the word resection for tumor? Because you don't just remove the tumor. You always remove it with a margin. With a margin of 1 to 1.5 centimeter depending on the aggressive behavior of the tumor. If it's a least aggressive tumor, just remove a 1 centimeter margin. If it's a very aggressive tumor, remove a broader margin. Okay. Now resections can be of two types. So these are two mandibles. Okay. If the tumor is limited to this much area, it's a small tumor. Okay, versus this is a tumor which is involving the superior and the inferior border. Okay, if I have to remove this small tumor, I will remove the tumor with a 1.5 centimeter margin like this. Okay, so I will remove this part. The continuity of my mandible is not lost. The continuity is still maintained. I have just removed a block of mandible. So I call it an N block or marginal resection. It's called an N block resection or a marginal resection or a resection without continuity defect. Okay. The other one where almost it's involving the lower border, to give a margin I have to cut like this. There is no way in which I can preserve the continuity of the mandible. This I will call a segmental resection. It's called a segment. The whole segment of mandible I am removing. Okay, so this is called a segmental resection or resection with continuity defect. That means there is a defect in the continuity. In this one, there was no defect in continuity. Here, there is a defect in continuity. Alright. A third example here I would also want to give is when you remove, when the tumor is something like this. So you have to remove not just the body region, but also the joint. Okay, so you have to remove this much mandible and take away all this. Okay, so when you remove half of the mandible, it is called hemimandibulectomy. Sometimes you have to remove the whole mandible. So that is called complete or total mandibulectomy. And whenever you remove the joint, okay, now when you remove the condyle, automatically you lose the joint because one part of the joint is condyle, other part is the fossa. So you remove the condyle, which is the articulation of the bone. Okay. So such resections where the condyle is involved is known as disarticulation resection. Okay. Disarticulation resection. That is a resection which is causing loss of articulation or loss of joint. Okay. So these are the three types of resections which you should know. Lot of questions are just asked on definition. And the last thing is basically, which is used in fibroosseous lesions, I am writing here, is recontouring. Surgical recontouring. That means just shaping. Suppose there is a masseteric hypertrophy, you just have to shape the bone. So remove the excess bone, it is recontouring. Fibrous dysplasia. You can't treat fibrous dysplasia because it is infiltrated as a diffuse process. So all you can do is whatever cosmetic correction you have to do, or whatever nerve compression is happening because of FD, you can just remove that compression and trim the bone. That is known as osseous recontouring, done in FDs or masseteric hypertrophy, such cases. Alright, coming back to our question, what is the meaning of marginal resection? Resection with discontinuity of mandible? No, that is segmental resection. Resection without discontinuity of mandible? Yes, that is what marginal resection is. Creation of bony window? That is marsupialization. And resection with normal bone margins? That is just any regular resection. Alright, so normal bone margins आप नहीं निकालते हो, 1 to 1.5 centimeter margins you remove. Okay, so that is marginal resection. Okay, coming to the next question, identify the procedure. You can see very, very clearly there is a defect in the palate. Okay, and in this it is stitched from between. So this is palatoplasty. Okay, palate surgery is done in the palate. Plasty means any repair or any repair. Just understand repair. Alright. Alveolar bone grafting, it is done here in the alveolar region. Pharyngoplasty, it is done here in the pharyngeal region. Nasoalveolar molding, it is done in cases of cleft lip. And alveolus to bring the lips, approximate the lips. So this is a palatoplasty, straightforward. Nothing to discuss here. Okay, next question is intranasal antrostomy is done through which meatus? Now what is intranasal antrostomy first? So I will just draw a quick diagram. Maxillary sinus, ethmoidal air cells, sphenoidal sinus, and frontal sinus. Okay, we know that these are the paranasal sinuses, and we know all of them drain into the nose. Okay, maxillary sinus drains into the middle meatus here. Okay, ethmoidal sinus, anterior ethmoidal sinus drains into the middle meatus. Posterior ethmoidal sinus goes into the superior meatus. Sphenoidal sinus in the superior sphenoethmoidal recess. Okay, everything drains into the lateral wall of the nose. Okay. Now, suppose I have done a surgery on the maxillary sinus. Okay, the surgery will cause some post-operative fluid, will cause some post-operative blood in the sinus. Suppose I have done a cancer resection, or suppose I have done a big cyst enucleation or a tumor enucleation from the sinus. So there will be post-operative exudate or transudate or collection in the sinus, right? Now, the natural drainage of the maxillary sinus is anti-gravity. Okay, normally the drainage should be like this, but God has made the drainage of the sinus like this. In normal health, in normal conditions, there are various ciliary lining, there is various cilia in the sinus which can just beat and remove the normal fluids from the maxillary sinus into the nose. But after surgery, this is a lot of fluid. There is a lot of transudate, lot of exudate, lot of blood, which cannot drain naturally through the ciliary lining. So, in this case, the surgeon does the drainage. How does the surgeon does the drainage? He does the drainage by fracturing beneath the inferior meatus here. He will fracture here, this wall between the inferior meatus and the sinus, and he will put a drain. Either he will put a gauze drain, or he will put any kind of drain. Basically, commonly we use a gauze drain. Okay, so we'll put some gauze piece like this. It will go into the sinus, and out of this is the nostril. It will come out of the nostril. This procedure is known as intranasal antrostomy. Intra means within, nasal means nose, antro means antrum, antrum of hymore, maxillary sinus, and stomy. What is stomy? Stoma means mouth. Stoma means mouth or opening. Okay, any opening or mouth is known as stoma. So you are creating an opening for the sinus through the nose. Intranasal antrostomy. Usually when we do maxillary sinus surgeries, we put this gauze and after 24 or 48 hours, we remove the gauze and that gauze brings all the collected fluids from the sinus. This is known as intranasal antrostomy. So in adults, we do the intranasal antrostomy through the inferior meatus because obviously that will be the only dependent drainage. If I do it through the superior meatus, ऊपर से anti-gravity I will have to bring the discharge. So I will do it as close to gravity as possible through the inferior meatus. But in children, if I have to do it in a child which is like less than 12 years of age, I will do it through the middle meatus. I will do it through the middle meatus because in children, the sinus is not so pneumatized. The sinus is still up. As the age advances, the sinus is pneumatized. It goes down. So slowly in adults, it comes down. In children, it is still high up. So you can still do the antrostomy through the middle meatus in children. In adults, you will do it through inferior meatus. And that is a very, very important question asked in NEET. You should know it. Okay. Now we have the last two controversial questions. Diabetic collapsing on a chair and steroid. Okay. A non-diabetic suddenly collapses on the dental chair and stops responding to command. Oxygen is being given, vitals are being monitored. What else will you do? First, I will tell you what is the two complications that can happen in a diabetic. Diabetic who is unconscious. Of course, he can have a simple syncope also. Anybody can have a syncope, but we should not think of syncope in a diabetic. In a diabetic who's gone unconscious, let me write three reasons. First can be syncope, which can happen with any patient, right? Second is hypoglycemia, that is especially common in patients who are on insulin. They have taken their insulin shot, but for some reason, they have not taken the meal. Or because of anxiety and because of the fear of dental procedure, they have become hypoglycemic. That is the second cause of unconsciousness. Third cause is excessive hyperglycemia causing DKA, diabetic ketoacidotic coma. Okay, diabetic ketoacidosis and coma. That is the third reason. So these are the three reasons why a diabetic can go unconscious on a dental chair. Most common causes. Rare to have a diabetic ketoacidotic coma on a dental chair. Very, very rare. Alright. So usually this will be ruled out. Okay. Now two options are left. Now depending on the language of the question, you have to know whether it is syncope or it is hypoglycemia. Here the question says that oxygen is already being given and vitals are being monitored. That is all you will do for a syncope. Syncope में आप वही करते हो. And what is left now? Management of hypoglycemia. And that will be your answer. You will give IV dextrose because he's a collapsed patient. He cannot take orally. Okay. Now, a confusion comes between students that whether you will do the blood testing first or whether you will give the glucose or dextrose first. Okay. I will tell you the flow of events. Diabetic, unconscious. Okay. Now, when he is unconscious, you can't give anything orally. Whatever you want to give, whether you want to give insulin because he is hyperglycemic or whether you want to give glucose because he is hypoglycemic, whatever you want to give, you have to give intravenously. Correct? You have to give IV. Now, practical scenario, when you put the IV catheter, when you place the intravenous catheter or cannula, okay, a 20 gauge or 24 gauge, depending on the vein size, you will put a cannula. At the same time, as soon as you put the cannula, you will confirm that it is in the vein because it will start giving blood. Same time, you collect blood for blood glucose and other tests. That is the first thing you will do. You will collect the blood for your glucose and other tests. Collect the blood. Alright? And immediately after that, you will give sugar. That is your dextrose solution. you will give your dextrose solution for management. Having said that, you will not wait for sugar test report. You will take the sample, because as soon as you put the cannula, you can take the sample at the same time. Whenever a patient, for any emergency, whenever a patient lands up into casualty, whenever a patient comes for an emergency in any department, whether it is gynae, whether it is ophtha, whether it is trauma, whether it's a child, adult, whenever a patient is coming to the trauma in an unconscious state, and you put an IV cannula to take care of his ABCDs and all of that, the first thing we do as soon as you put the cannula is you take a sample. Cannula dalte hi, you will take a sample and send it for all the required tests. Now, when you have taken a history that okay, he's diabetic, you will not wait for the test results. You will give the primary management, which is sugar, which is dextrose solution. Why? Because either he will be hypoglycemic, in which case dextrose will give immediate result. Sometimes even before the result of the blood glucose test comes, as soon as you give glucose, the patient is conscious and he becomes normal. So it will give you an immediate result. As soon as you give IV dextrose, whatever is available, 5%, 50%, whatever is available, as soon as you give it, suddenly the brain and the cells will have glucose and the patient will become conscious. So it will give you an immediate result of your problem. And you keep getting the result of a blood glucose and you keep giving insulin and keep doing everything else. Okay. The other situation is, what if the patient is hyperglycemic? What if he is hyperglycemic and you are giving dextrose? Look, a hyperglycemic patient, just because of one episode of hyperglycemia, doesn't go into DKA. A hyperglycemic who is on constantly increased blood glucose will have a ketoacidotic or a very anaerobic environment in the body, and in that situation, giving a little bit of dextrose is not going to harm, is not going to do anything. Only thing, the patient will not recover. And in that case, you will have an idea that, oh, maybe it is not a hypoglycemia but a hyperglycemia. So this awareness can come even before you get a test result, even before you get the blood glucose test result. Okay. Now, if the examiner give you options like you have a blood glucose strip or you have a glucometer which gives you immediate results, yes, then you can just do a prick, do a glucometer test, and immediately you will see the blood sugar, and you then for 10 seconds you can wait and then give the dextrose. That much is okay. But taking a proper blood sample, send it for lab report, getting the lab report, you don't wait. Yes, you send the sample as the first thing because you put the cannula, you take the sample. But start the treatment, and the only treatment is dextrose. If it corrects, you have already done the treatment. If it doesn't correct, anyways it will not harm and you will treat it in the lines of hyperglycemia. Alright. So the flow of events is, take a sample, don't wait for result, give dextrose and monitor. Alright. So this is the correct sequence of management of a diabetic patient who is on insulin or who collapses on a dental chair. Sometimes the patient will give the diabetic option just to confuse you. The examiner will give you the option of diabetic just to confuse you. And he will give the signs of syncope. So make sure that you are not ruling out syncope. Syncope should also be in your mind. And hypoglycemia should also be in your mind. Alright? Okay. Coming to the last controversial question about steroids. Okay. A patient undergoing a dental surgery collapsed on dental chair and became non-responsive. History showed that the patient was on 20 mg prednisolone for eczema for the last 6 months. Following collapse, the patient was given oxygen, vitals were monitored, and extra steroid 100 mg hydrocort was given IM. What is your treatment directed towards? What are you treating? Basically, you are treating acute adrenal insufficiency. So this brings us to the question that should every patient who is on exogenous steroids, should every patient be given preoperative doubling of steroids? The answer is No. Let us understand the steroid story. Where does steroid generate in our body? So, hypothalamus, pituitary, adrenal gland. Okay, we are talking about the adrenal steroids, not the gonadal steroids. Okay, adrenal steroids, mainly the adrenal cortical steroids. Okay, and isme main are your cortisol and aldosterone. Two main mineralocorticoids and glucocorticoids are cortisol and aldosterone. There is a negative feedback. So whenever there is enough cortisol in the blood, enough aldosterone in the blood, it will signal the hypothalamus that we don't need anymore. So hypothalamus will not give any releasing hormone and adrenal will not produce. Okay, just like you can see here. Okay, so, okay, it's not there. And whenever there is a shortage of cortisol, it will quickly signal the hypothalamus that the body needs cortisol. Please generate some adrenocorticotropic releasing hormone. And adrenocorticotropic hormone releasing hormone will be released from hypothalamus. ACTH will be released from pituitary and adrenal will secrete cortisol. Okay. Now what are the situations in which the body needs extra cortisol? Stress. Clinically relevant situation is stress. Whenever there is stress, what kind of stress? Fever, fear, anxiety, everything combined, surgery, pain. Okay, so fever, fear, anxiety, pain, everything is there when you are going for a surgery, intraoperatively and postoperatively, right? So these are the things when the body needs extra steroids. Okay, but how much extra and which steroid? Okay, when a patient is taking, okay, let me first tell you what are the two types of adrenal insufficiencies. There are two types of adrenal insufficiencies. Okay, first is primary adrenal insufficiency. That means the adrenal gland itself has a problem. What are the situations in which the adrenal gland can have a problem? There is a tumor in the adrenal gland, or adrenalectomy, or some autoimmune disease, or some infections like tuberculosis or HIV. It is affecting. Whenever there is a direct adrenal gland problem, okay, adrenal gland disease, it will cause a direct impact on the body and it is called primary adrenal insufficiency. Lifelong the patient has to be on exogenous steroids. Okay, just for a replacement. Next we come to secondary adrenal insufficiency. That means it is not primarily because of the adrenal gland. It is because of either the hypothalamus or pituitary problems. That means ऊपर से signal नहीं आ रहा है. So hypothalamus or pituitary problem. Or the patient is taking exogenous steroids. When the patient is taking exogenous steroids, his HP axis is suppressed. Now, very important point here is, when you take exogenous steroid, which steroid do you take? You always take a cortisol substitute. Usually, the exogenous steroids that are prescribed are replacement for cortisol. Okay? Aldosterone is still functionally being produced in the body. So, secondary adrenal insufficiency इतना problematic है ही नहीं. It is not a problem at all. Hardly it will create this situation which is shown here, which is acute adrenal insufficiency. This will usually happen in primary adrenal insufficiency. And ये जो exogenous steroids से हो रहा है, that is very 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 rare to have this situation because of secondary adrenal insufficiency. Okay, first is this. Second is, whenever this is a table which you have to learn. It is there in our notes. I have taught it in my class. Please understand this table very very nicely. When a patient comes to you with primary adrenal insufficiency, you have to do a dose modification depending on whether it's a routine dentistry like RCT and restoration, or whether it's a minor surgery like few simple extractions or biopsy. whether it's a moderate surgery or whether it's a major surgery. All this is there when the patient is of primary adrenal insufficiency. When the patient is of secondary adrenal insufficiency, that is exogenous steroid wali category, no dose modification is required. You can just continue your procedure with your daily therapeutic dose, except when there is anxiety, infection, health is poor, major surgery under GA, ऐसा कुछ है, then only you will give some little extra steroids. Otherwise, in most cases, suppose the examiner is giving you a question that a patient is taking exogenous steroids, he is taking Vizolon or Prednisolone, 20 mg daily, and he needs extraction of 2 periodontally compromised teeth. Just do the extraction. You don't, except for the daily dose, whatever dose patient is taking, yes, that he should take. But no need to double the dose at all. As per the current guidelines, you do not need to double the dose. Okay? Same, and if you need to give extra steroids, if the patient is of primary, then what will you give? Okay? You have to give equivalents. What is equivalent? Now, 25 mg hydrocortisone, everything is compared to hydrocortisone. 25 mg hydrocortisone or cortisol is taken as 1. अगर आपको इतना replace करना है, like in a minor surgery, you have to give 25 mg hydrocortisone, you can give 25 mg cortisone, or you can give 4 mg methylprednisolone, or you can just give a 0.1 or 3/4 mg dexamethasone. You can replace with any of these things. So this is known as a conversion or equivalent. 25 mg cortisone is equivalent to 4 mg methylprednisolone, which is equivalent to a 0.75 mg dexamethasone. And the duration of action is different. So depending on your severity of surgery, depending on the status of the patient, you will choose. Okay. But having said that, most of the surgeries do not require a replacement or a doubling of steroids. Because most of the times, if the patient is taking exogenous steroids, it is okay. You can still perform the procedure. Yes, in GA, if you're taking the patient under GA, yes, the anesthetist might give a little bit of steroids just for the general risk of GA, not because of the surgery per se. Okay, that is why now there is divided into minor and moderate and major surgery. Now, what is minor surgery? Minor surgery like few simple extractions or biopsy. Then, if it is a primary adrenal insufficiency, you will give replacement. But if it is a secondary adrenal insufficiency, you do not need any replacement. Major surgeries like multiple extractions, periodontal surgery, extraction of impacted teeth, bony surgery, cancer surgery, osteotomy, or any major surgery, in secondary anesthetic adrenal insufficiency, mostly you do not need any replacement. Except if the patient is going under GA, or if there is infection and excessive pain, you can give a little bit of steroid. Otherwise, in most minor surgeries, for exogenous steroids, just give the daily dose. Whatever patient is taking, no extra dose is required. Same guidelines are there by Australian recommendation. Same guidelines are there in the New Zealand recommendations. And same guidelines I have shown for US FDA also. Okay. So when the patient is taking less than 7.5 mg prednisolone, that is Vizolone, don't need any supplementation even for GA. Same for New Zealand. If he is taking slightly more than 7.5, LA, double the dose on the day of surgery only, and if it is a major surgery. And for GA, you definitely give steroids for GA. Okay, 100 mg hydrocort pre-operatively or intraoperatively, maintain it, and post-operatively also you will go for the steroid replacement. Okay, and if the patient is taking a lot of prednisolone, that is greater than 20 mg prednisolone, that's a very high dose. Then even in that case, no supplementation is required for minor surgical procedures. For minor procedures, you still do not need any supplementation. Only for major surgeries under GA, you need a replacement dose. Alright? So, any patient who is on exogenous steroids is having a secondary adrenal insufficiency. In such cases, minor surgery, you do not need to increase the dose. That is the baseline. Okay, that is the basic line behind the whole discussion. Only when the patient is taking very large dose of steroid and he's undergoing a major surgery under GA, yes, then you will use this protocol, and then you will give a pre-operative dose also, an intraoperative dose also, and a post-operative dose also. For local procedures, for small dosages, in secondary adrenal insufficiencies, you do not need to step up the steroids. All you can do is just give a little bit of antibiotics post-operatively so that infections are less, because these patients are also immunocompromised. That's all you need to do. Alright? So with this, we have covered the most important PYQs in NEET and the most controversial questions also. If you guys want to ask anything, we are open to discussion. Otherwise, thank you so much for the patient listening. All the best to all of you for the upcoming exam. Okay, there are certain doubts. Oh, I missed these doubts. Okay, there are some doubts here. Why steroids are taken during fever and stress? Because they increase the need for cortisol in your body. Cortisol is a hormone which balances the fluid and the other electrolytes of your body. Okay, this is the function of cortisol. So this is for Nami. Nami, this is for your doubt. Cortisol balances inflammation, bone formation, muscle mass, glucose, and the kidney function, emotional modulation. So this is a very important hormone for post-operative recovery also. Okay. So you need cortisol anyways after surgery. So you always give, even if the patient does not have any adrenal insufficiency, you always give the patient steroids after GA or during GA, because all this is need to be taken care of. So steroids are very, very useful, and that is why you give it in such situations. Alright? Okay. Smile is asking, when there is no problem in occlusion, why do we use IMF? When there is a simple symphysis fracture but occlusion? Because the discrepancy is not there at rest. When the mandible will come in function, then the segments will open close. It will move. And any mobile bone will cause a non-union or a fibrous union, which is abnormal healing. So because mandible is, if it would have been maxilla, I would have left it. But mandible is not a static bone like maxilla. It's a mobile bone, right? So you need to do an IMF, because mobile bone, the fracture fragments will not heal. Alright? Smile, is that clear with you now? Please tell me if it is clear with you. Please explain palatopharyngeal incompetence and insufficiency. Alicia, this is your doubt. Beta, it's a very wide topic. You can go to the cleft lectures that I have taken. I have very nicely explained the velopharyngeal incompetence. You can go there and watch. It's a very wide topic to explain in this doubt session. Alright, please go into the cleft lectures of the oral surgery and watch in detail the velopharyngeal incompetence and the velopharyngeal mechanism. Okay, Smile, I have answered your doubt. Okay, least stable, unstable, OSA, ankylosis. Okay. What will we do for graft overgrowth? So Ayush Sharma is asking me what you will do for graft overgrowth. Very good question, Ayush. So in graft overgrowth, we go back. We do a secondary surgery. We open the same incision. We open again. We remove a large part of the graft and very little bit of cartilage we leave. Okay, so you have to resect the excessively grown graft. If you have attended my live lectures, I have shown my surgery during my PG times, which is a costochondral graft done in a child, and he came back with a graft overgrowth, and we opened again. We opened the joint. We removed a large part of the overgrown graft, and left it. So that corrects the asymmetry and that brings back the growth potential to near normal. Okay, so Ayush, that is what we will do in graft overgrowth. We will resect the excessively enlarged graft. Okay, how to differentiate between transient and permanent facial palsy? Whatever is recovering is transient, whatever is not recovering is permanent. There is also a House-Brackman scale to tell you about the facial nerve palsies. So Akash Sinha, this is your doubt. How to differentiate? Whatever is resolving is transient. Okay, normally it is transient. If you learn surgery in a proper way, you will not damage the facial nerve. Whatever is not resolving is permanent. Okay, if possible, explain grading of facial palsy. It's a House-Brackman system. Nothing to explain there. You have to mug up the points. There's nothing to explain there. John Das. You can read the House-Brackman system. It is there in our notes. Very easily you can just mug up the points. Alright. Okay. So, you do get a pen. Ada. You do get a pen. If you don't get a pen, you can ask for it. Okay. Last NEET, in my center, there was no pen. But all those who were asking for a pen, they were given a pen. It's not as regularized or as proper as INI exam. There are a little drawbacks in NEET. But still, if you ask for a pen, they can't deny you. They will give you a pen. Okay, Ada. So, you can ask for a pen. Okay, so I think I have answered almost all of your doubts. All of your doubts rather. And so Fayaz is asking me in terms of stability, which orthognathic surgery will give more stable results in correction of severe class 3? Your question is incomplete. Class 3 can be because of two reasons. Class 3 can be because of an mandibular protrusion or it can be because of a maxillary retrusion. So what is the cause of class 3? First you have to see that. If it is because of a combination, you have to do both. You have to do a Lefoot 1 also and a BSSO also. Okay. And in that you will divide maxillary advancement and mandibular setback. If it is a small setback, do BSSO. If it is a major setback, do IVRO. Alright. So a class 3, a skeletal class 3 can be because of maxillary hypoplasia or maxillary retrusion or mandibular protrusion. Okay. Usually it is a combination. So that is why usually in such cases you do a bi-jaw surgery and you divide your correction between maxilla. So suppose the difference is 17 mm. So 5 mm you will correct maxilla and 12 mm you will correct mandible. And depending on the size of the mandible, the tenseness of the sling, you will decide whether you will go for a BSSO or a IVRO. Yes, definitely. It is always said that a bimax surgery is always more stable than a single jaw surgery. A bi-jaw surgery is always more stable because it divides the discrepancy between the two jaws. So usually all the surgeons prefer doing a bi-jaw surgery so that the results are more predictable. The movements in individual jaw is less. Alright. So Fayaz, I hope your question is answered. Just tell me a thumbs up or give me something so that I know that you've understood. And as usual, my 1 hour session has gone to a 1.5 hour session. Most of you are hungry. So you can go back, eat your dinner. And still if there are any doubts, you can find me on Instagram, on Facebook, on DBMCI MDS YouTube page and many other places. And every day in the morning motivation session. So you can just clear your doubts, whatever you have. Alright. So with that, we will finish the session here. Good night everyone. All the best.